Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have the pleasure today of having three separate neurosurgeons that are going to present on updates on cervical spine injuries. And I'll turn it right over to Salim right now. Well, sure. Dr. Sharif, I don't know, I'm having a blank, I'm sorry. Okay, okay, Dr. Sharif, it's all yours.
Okay, thank you, John. It's really our pleasure to come here today. I was asked about a month ago to do this, to have a series of seminars, and we said we're going to pick up topics and we'll try to cover those topics. So today we found a time which was very difficult because our own webinars are going on and it's very difficult to find time. So here we are. We're going to start with cervical spine trauma. I think there are 3 sessions. My esteemed neurosurgeon, dear friend for ages, Mehmet Zalili is here, who will be talking about CV junction. Nicolai Peeve is going to be joining in soon, which he'll be talking about subaxial cervical spine, and I'll start with acute management of cervical trauma. So these are some of the guidelines that we have. And let's see. Can you see that?
Yes, we can see it.
Okay. So this is actually curriculum range, and if I'll just show you, here we have K2, which is the second tallest peak in the world. And in this range, we have about 14 peaks out of the top 30 peaks in the world in this Himalayan curriculum range. And it's an amazing area. Well, subaxial, what basically I'm going to be talking about today is actually a cervical spine trauma and its emergency management. So who are the patients who are at risk? Patient come into ER, so all patients who sustain polytrauma, unconscious trauma patients, minor trauma with neck pain or tingling in their hands or any neurology. So, these patients we need to be suspecting about trauma. And yes, can we make an impact on making a difference by assessing patients early? So 3 to 25% of cases of permanent neurological impairment after spinal trauma have been attributed to injudicious manipulation by us, paramedical personnel, examining physician, or radiology technician. So, somebody is trying to be extrapolated from an ambulance or from a car. And by that, if they have a cervical injury, they're pushed out, and this is a problem. And we all need to know how to immobilize the spine. I think that's important for us. Who are the patients that we need to intubate? We know this: respiratory failure. If PCO2 is more than 50 millimeter of mercury, pH less than 7.3, a respiratory rate of 20, then you need to be thinking about respiratory failure. Intubation may complicate opportunity for close reduction. So because patient is awake, then it's easier for close reduction awake and patients who are communicating. Assume that patients who are C4 and above, any injury C4 and above, Asia C and below, will fail to maintain a respiratory effort in acute phase. So these are the patients you need to be thinking about, that should I intubate them straight up. Most important spinal cord injury indicator is the mechanism of injury. So there are types of injuries: flexion, extension, compression, flexion rotation, distraction, and penetration injury. And all of them have a certain role to play in what kind of fractures they will get. By mechanism of injury, if you have flexion, then you can get anterior subluxation injury, unilateral facet dislocation, bilateral dislocation, wedge compression fractures, flexion teardrop fractures, Fleisch lower injury. And in extension, you're going to get Hangman's fracture, and obvious because if you go backwards, your posterior ring is in trouble. Compression, if something hit from the top or you go down on your head, then you can get Jefferson fractures or burst fractures, and complex could be odontoid. I'm not going to go detail into it, but just going to touch briefly simple wedge compression fractures without posterior disruption, flexion teardrop fractures. These are all flexion injuries. And bilateral fracture dislocation and anterior Atlanto-occipital subluxation. Flexion rotation, you could have unilateral and bilateral. How do you know it's unilateral? Because less than 25% of subluxation we can see. And if it's more than that, you can think about bilateral. Patient's neck is turned as well, and a rotatory atlanto-axial dislocation you can have. Some of these patients have serious issues with complete dislocation, but here, this patient was lucky to survive. So there are simple anterior reduction techniques, or you can have posterior reduction techniques. The first thing is, would you put a tongue in somebody who comes in with fracture or dislocation? Yes, you should. As soon as you have a CT scan and you're able to immobilize that patient and patient is stable and there are no other injuries, the first thing you need to do is put in tongs. And if you can put in tongs and put, depending on what level it is, you increase your weight accordingly. And if that is the case, in majority of the cases, you're able to relocate the dislocation, subluxation if it's done within 4 days, 5 days, or acutely if it's that day. And so once you've reduced that, straight away as you put in the tongs and weight, you're able to take away the pressure from the spinal cord, and you're able to relieve that patient. You're able to create more space in the spinal canal, and thus all that problem could be sorted. If you're unable to do that, then if you go in anteriorly, you can reduce this. I had a patient yesterday exactly like this. So all I need to do is I put in 2 of these screws above and below and distract it, and automatically you're able to reduce even from front. Or the other way to do is use any kind of a shovel, or you can use simple distractors of any kind. Then there are various other maneuvers that you can do, which are shown here. And it's a very nice paper written by Ed Benzel ages ago. Posterior reduction, obviously it's very simple. If there is a joint coming in the way, you can drill it and reduce it, unilateral, bilateral, or you can hold it by holders above and below and able to move it up and down. So all that is possible, very, very simple. We need to know about ASIA-A. And there's a specific reason for that, because everybody worldwide uses ASIA, and we know that what kind of injuries we're talking about. So there are international standards, and motor and sensory assessment is important. An ASIA impairment scale is from A to E, and there are some clinical syndromes you need to know. This is the chart, and if you use this chart all along with what kind of injury you've had, what kind of maximum motor injury you have, or minimum motor injury, and these are specific motor key muscles, and there are key sensory points that you need to examine. And you need to know this well if you're a resident or trainee, or you're calling somebody on the phone and letting them know what kind of injury has come in. So why is all this important? Because I'll just tell you why. If it's a complete injury, no motor or sensory function is preserved in sacral segment S4 to 5, compared to a B injury, in which although there is no motor function, but you may have sacral segments preserved. C is when, obviously, if the half of the key muscles below the neurological level have muscle grade less than 3, and if it's more than 3, then it becomes D, and normal is E. And I'll tell you why all this is important. Neurological assessment, obviously rectal examination, tone, and looking at sensation, looking at volition, and specifically looking at bulbocavernous reflex. Well, because that tells you that if you tug on the Foley's catheter, or squeeze the glans or clit, or look at it electrophysiologically, if the reflex is positive, implies the lack of supraspinal input to sacral flow, suggestive of complete spinal cord injury. So positive obviously means that there is complete injury. Negative is when it's absent in spinal shock. So you can differentiate, and these patients will improve. What about the recovery? If you've got ASIA, that means you have no sensory or power. We know that 11% of them will improve, and 3% will improve to some kind of walking if they're treated aggressively. So you need to understand that ASIA does not mean end of story. There are some patients who are going to improve, and there are some patients who are going to walk again. If you look at the difference between ASIA and B, it's 11 to 44%. So 1/4 of these patients will walk again. So it's important to understand that just by improving that, having that sensation in the sacral area, you need to be aggressively with these patients. Then if you come to ASIA C, they improved 55% improved to ASIA D and E, since some of them will worsen, whereas majority of ASIA D will improve to D and E. So this A and B is very important to differentiate. That's why you need to go and examine these patients every hour. The first reliable ASIA score is at 72 hours. So there is this famous soccer player who had an injury, was told he had complete injury, and he walked out of the hospital after 10 days. And the reason was obvious, that he was in spinal shock, which wasn't picked up. Why these patients improve? Because pinprick sparing predicts motor recovery. And for the reason that is that you have got these tracts right next to each other. So the posterior columns and corticospinal tracts, spinothalamic tract and corticospinal tracts are right next to each other. And that's why when you have an injury like that, you can have an overlapping recovery. So imaging studies, what imaging studies do we need? Do we need plain x-rays? No. CT scan cervical spine? Yes. MRI? Maybe. Plain x-rays are insufficient, have been shown in multiple studies. If you don't have a CT or MR, then you do an AP lateral x-rays. And as soon as you get a CT, you get that. So the indications are very clear. If there's no CT available and you have neurological deficits, polytrauma, craniofacial injury, unconscious patient, then you should get an x-ray. On the other hand, if you have a CT, which you should as soon as possible, you need to have sagittal reconstruction of the CT, fine cuts through it. And if you do that, obviously you're able to pick up small things that MRI or x-ray may miss. MRI is very helpful in brachial plexus injury. It's helpful for our prediction of the outcome. You can see it ligaments, disc, cord damage, what kind of contusion there is. So if you see in this particular patient, you can see this contusion, which is, I will describe later on different types of contusion. So awake close reduction, yes, 554% of disc herniation, no neurological compromise in awake and alert patient who had this reduction. So if patient is awake and you reduce it, even with a disc prolapse, it does not give you a neurology in majority of these studies that have been done. So, so many of them had disc herniation, but did not show any correlation to the outcome. So you can reduce as soon as possible because all these studies are there to tell you that you should reduce. Tongs, when you apply, so you have got displaced deficient fractures, Hangman, type 2 and type 3 odontoid, displayed subaxial fractures, and subaxial subluxation and dislocation. In the Hangman type 2A fracture, if you put out traction, you may cause problems to the spinal, further problem to the spinal cord injury and subsequent death. So it's contraindicated in type 2A fracture. What about the classification? So two main classifications that we use routinely. There's Vicari's subaxial injury classification, which was published way back in 2007, and in which we divide that according to morphology, discoligamentous complex, and neurology. Morphology, so there's no abnormality. If there was compression, if there was burst and distraction and traction rotation. Discoligamentous complex, it was involved or not, depending on that, you can see it on MRI, or CT, when you see those posterior elements gone or a little bit of blood spillage. Then neurological status was important to look at. If it's intact, you get 0. If it's root injury, 1. With spinal cord injury, you get 2, whereas with incomplete injury, you get 3. So you need to be more aggressive. The more higher the score, you're going to operate. And if you've got continuous and continued compression with neurology, you add 1. So then depending on what score you have, you can decide you're going to operate or not. So SLIX and CSIS were the two studies that were done at that time, and they looked at different reliable overall indicators, and the reliable coefficient was up to 0.7%. So it was consistently reliable. So for example, this patient who was 25-year-old driver, neck pain, tingling in arms, no neurology. So if you have no neurology, you get 0. Discoligamentous complex is not involved. The back part is okay. And you look at M2, and because of that, obviously you're going to get a score of 2. This patient does not require surgery per se. AO classification came out again by Vicari's group, and they had each region was classified according to their hierarchical system with increased level of injury or instability, and represents the morphology of the injury, neurology, and clinical modifiers. Can we mute this person? Thank you. Okay. So morphological classification, compression, same kind of concept, failure of posterior anterior tension bands, failure of all elements leading to dislocation or displacement, and additional description for facet injury, F. And so injuries are classified by their level either or C, B, or A. And I'm going to show you. So compression injuries were A. They were divided into 5 subtypes. No bony or minor injury, A0. Compression fractures, A1. Coronal split or a pincer fracture, A2. A3 is burst fracture, A3 burst fracture with sagittal split injury involving both end plates. So you can see A0, which is normal, A1 wedge, A2 split, A3 displaced transverse fractures, and completely burst was A4. Tension band injuries, they're subdivided into 3 groups, and those groups are, if they involve the spinal canal, if there's a transalar fracture going all the way across, does not involve foramen or spinal canal, and the one
please
that
go slow.
I'm sorry. I thought that we were revising this because this was AO, but I will go slow, no worries. So transforaminal fracture involvement, but not the spinal canal, then you get B3. So you've got B1, B2, B3, and I'm just going to go and revise A0, A1, A2, A3, and A4. So you've got, depending on morphology, we are dividing them into different types. Translational injury in any axis, any associated injury, either type A or type B or type C. So translational injury in an any axis displacement of one vertebral body related to the other, and its complete movement, you get type C. Facet injury, we have this specific type, which is called F, and you've got F1 when it's non-displaced. Maybe I'll show you the figure. Non-displaced facet, so you've got a fracture, but it's non-displaced. Facet fracture with potential for instability, so you've got fracture, and there is potential instability because both anterior and posterior are involved. And then we have got floating, that you've got fracture of 3 bones here, leaving it completely free, so the facet is, and lateral mass is free. So, and then you've got pathological subluxation, that the whole thing is subluxed or pursed or dislocated facet. So we see this quite commonly. So it's F1, F2, F3, and F4. And then the one is called BL when you've got bilateral injuries. And then method to classify is very simple. What we do is we use both TLEX and we use AO. We're comparing this for last 6 months, and we want to do a big study, and maybe at least after a year, and follow these patients and see what happens and which is more of a predictor than the other. So you start with displacement, dislocation. If it is yes, you automatically become translation. If there is no, only tension band injury, then you've got anterior and posterior. Depending on that, you get hyperextension B3. B2 is osteoligamentous, which is posterior, and pure transosseous disruption. Then only bone is through bone that its fracture is happening, then you get B1. On the other hand, if there is no tension band, then you come to vertebral body fracture. And if there's posterior involvement, yes, then it becomes A4 and A3 that we saw burst and incomplete burst. Whereas if its posterior wall is not involved, then you get both end plates involved. So you get split or wedge. So you just need to go through these, apply it on some of your patients. This is available free of charge on the AO website. You can download it. You can get a poster. You can put the poster on the wall, and you can see it, and it's very, very simple. So that's how we classify. And then AO previously did not have any neurology into it. They recently introduced neurology into it, and it's made that very strong classification system. So they put the same classification neurology system that TLEX nearly had. So N0, you've got neurologically intact. N1, transient neurological deficit, which is no longer present. N2, patients with signs, symptoms of radiculopathy only. N3, incomplete spinal cord injury or cauda equina. And 4, complete spinal cord injury. And NX is used to designate patients who cannot be examined because of head injury or any other condition, intoxication, multiple trauma, confusion, intubation, or sedation. So neurology comes exactly like this, and not N1, N2, N3, N4, NX. And you add 1, which is due to continued spinal cord compression. That's how we had in TLEX. TLEX is very simple. But AO, once you use it in your patients, you get used to it. And then there are case-specific modifiers. So because they realize that if you've got other things that can make a difference into the outcome of these studies. So M1, you've got posterior capsular ligamentous complex injury without complete disruption. M2, critical disc herniation, which wasn't addressed before. M3, stiffening, metabolic bone disease. So if you've got DISH, ankylosing spondylitis, OPLL. So these are high risk factors. So they put that into account. And M4, when there are signs of vertebral artery injury. So that was the two classification system. TLEX is simple to use. Majority people are using it. AO people push AO to be used. We are using both, and I think both are at the moment equal. TLEX is easier, and for simplicity, you may use it. Both have shown that they can be they're reliable, and you can use it again and again. Radiological assessment: awake, asymptomatic patient without any neck pain do not need any more investigation. Okay, and they don't need to have a collar on that. In awake symptomatic patient, high quality CT scan of the cervical spine is recommended. Obtunded patient, high quality CT scan of cervical spine recommended. If CT not available, you can have a 3-view cervical spine, but this should be supplemented with CT as soon as it becomes available. How about methylprednisolone? There's a lot of debate, talk about it over the years. Treatment options for acute traumatic non-penetrating spinal cord injuries include the administration of a high dose of anti-inflammatory agent, methylpred, within 8 hours. So when Brecken did all these studies, when he did his third study, he said methylprednisolone failed to demonstrate an effect in comparison to placebo. Additionally, due to increased risk of infections, its use is no longer recommended. So there's this paper which said that reporting of the results of NASCUS studies, that Brecken studies 2 and 3, have been incomplete, leaving clinicians in the spinal cord community to use or avoid using methylpred in acute spinal cord injury on the basis of faith, rather than publicly developed scientific consensus. In other words, administration of methylpred for treatment of spinal cord injury is not recommended. It's not approved by FDA. There is no class 1 or class 2 medical evidence that we should use it. There is evidence that high dose steroids associated with harmful side effects, including death. What about aggressive cardiopulmonary resuscitation? There are guidelines clearly now by NAS, by all the organizations all over the world, to keep the MAP more than 85 in order to have a better outcome compared to patients who did not have that. So the guidelines clearly say, AANS recommended that maintenance of MAP between 85 and 90 for the first 7 days following acute cervical cord injury is recommended. So all our patients are kept in high dependency unit, and their MAP is kept up in order to get extra improvement in these patients. And we see these patients improve if you really do that. So there is level 3 evidence regarding that. I was talking about a score which can tell you how these patients, have a reasonable outcome. This is the score that I was telling you about. So this is a basic 0, in which there is no intramedullary cord signal. So you've got some completely normal. Basic 1, when you've got only T2 hyperintensity in the central gray matter, whereas when it's T2 going beyond gray matter into the white matter. And once you have whole of the white matter involved as well, whole of the cord involved, then become 3. And 4 is when you've got contusions as well in it. And we have seen that here, as your score goes up, the outcome goes worse. So if you had a reasonable score of basic 2, all these patients will improve. Whereas with basic 4, none of the patients improved who had also hemorrhage along with big contusion. So we know this, that majority of the patients in basic 3 would improve, but still, many of them will not improve in these patients. So early surgical intervention, yes, if you operate within 6 hours, there's a 12% chance of that improvement. Staskus showed the same, that you can go up to 2 Asia grade at 6 months follow-up when you're operated within 24 hours. So recommendations, obviously close reduction, early reduction. And we recently had WFNS consensus on this, and WFNS Spine Committee had this consensus that management of log facet, if a posterior approach is considered, preoperative MRI may be recommended. Traction help in immobilizing the unstable segment and may help in reduction. majority of acute lock facets, anterior surgical techniques are sufficient to manage successfully. In chronic facets, more than 2 weeks, lower cervical lock facets with no significant disc prolapse can be done with our posterior approach. We hope to have this 33rd annual conference of Pakistan Society of Neurosurgeons and WFNS International Symposium in Karachi and from 5th to 8th November, depending on how COVID behaves with us. And these are some of the webinars that are going on every day with Pakistan Society of Neurosurgeons, some anatomy webinars, and some from some famous neurosurgeons all over the world. So you all are most welcome. Thank you, John. Thank you for giving this opportunity.
Okay, gentlemen, excellent. Now, how do you want to basically moderate the panel?
Okay, no problem.
Yeah, why don't you just moderate yourself?
Okay, let me just stop sharing. I would request my dear friend, Mama Zalili, who will be talking about CV junction trauma. And this is a symposium that we're doing for cervical spine updates. Yes, Mama.
Okay. Thank you for giving this opportunity to share our information with a big number of participants. I think I'm sharing.
Yeah, you just need to.
Yes.
Yeah.
Is it okay?
Perfect.
Yes.
I will try to give some information about craniovertebral junction injury and fixation techniques. In fact, this region has a unique anatomy, and we have to be aware of the measurements of the region. Although we do not use too much direct X-ray measurements, but we can still use them in the sagittal CT scans. One of them is Atlanto-occipital anterior atlantodental interval. It's 3 millimeter or less in adults. In children, it may be 4 millimeters. The other one is the posterior atlantodental interval. It must be more than 13 millimeters. If this is the measurements, this is the anterior atlantodental interval. This is the posterior atlantodental interval. There is one rule of Spence, although in the past we have used it too much. This is the displacement of lateral masses of C1 over the masses of C2. So this measurement plus this should be less than 6.9 millimeters. If it's more than 6.9 millimeter or 7 millimeters, it means the C1 burst fracture with tear of the transverse atlantal ligament has happened. The tear of the transverse atlantal ligament is a very important feature of the region. If it has torn, and then we expect the spinal cord compression, and also most of those cases will have neurologic deficits. However, then some other authors have examined the rule of Spence. It's not found very accurate for assessing the integrity of transverse atlantal ligament. 60% of patients with the TL rupture would not have met the rule of Spence criteria. So, although it is still there, we must ask if it is really necessary. I will not mention too much about the occipital condyle fractures and Atlanto-occipital dislocations because they are very, very rare. Although some occipital condyle fractures can be seen more often in a very high resolution CT scans. Some clinicians cannot see that, they overlook it. And especially if it is an emergency case, the CT scans may not be evaluated by the expert radiologist at the time of night duty especially. For Atlanto-occipital dislocation, there has been a historical trinaris classification. That author has identified type 1, type 2, and type 3. Type 1 is occiput has anteriorly dislocated. In type 2, posteriorly dislocated. And type 3 is just distracted. These are just anatomical features of the Atlanto-occipital dislocation. Probably that MR measurements of Harbor View classification are somewhat more reliable. In those classifications, stage 1, stage 2, and stage 3 have been described. If the distraction is less than 2 millimeters, especially on provocative traction radiogram, if it is just 2 millimeters or if it is more than 2 millimeters. If it's more than 2 millimeters, then here the medulla oblongata may got injured, and also the vertebral artery and some veins may got injured, and the ischemia of the region and significant traction of the region may cause very fatal injuries. And in those injuries, the mortality rate may reach up to 30%. This is the Powers ratio and other direct radiogram measurements have low sensitivity. Probably this condyle to C1 interval, if it's more than 1.5 millimeters, it is real instability sign. Let's come to atlas fractures. Atlas fractures are more common. We know all that Jefferson have classified them, but the recent classification from Weiler, a German author, describes that in five groups. This classification integrates Patterson and Dickman classifications. Weiler type 1 and 2 and type 5 are stable fractures. Type 5 is actually important because it is crossing the vertebral artery foramen, so then the injury to the artery may happen. That the injury to the artery must be excluded by the angio-CT. However, Weiler type 3A is a stable ligament intact. Conservative therapy in a hard collar is possible. You must follow up those patients, exclude dislocations, non-unions, and a possible Atlanto-axial instability. Weiler type 3B is considered as an unstable fracture because of the transverse ligament is not intact. These cases must go to a Atlanto-axial fusion surgery with some post-op hard collar application. Type 4 injuries, if it is a minimally displaced, hard cervical collar is enough, but some rare cases may have dislocations and may need a halo fixation for long periods. Let's come to the odontoid fractures. The Anderson and the Alonso classification has been used for many, many years. It's from 1974. Type 1 is very rare. It is just on the tip of the odontoid process. Type 2 is in the basis of the odontoid. Type 3 is crossing the body of C2. But in 2005, Grauer and co-workers have subclassified that Anderson and the Alonso classification with type 2A, B, and C. Type 2A is a non-displaced fracture. You can go conservatively. Type 2B is the fracture line is anterior superior to posterior inferior. You can then go to a anterior odontoid screw fixation. Type 2C is anterior inferior to posterior superior fracture line or a comminuted fracture line. So this the treatment is rigid collar in two of them. Odontoid screw is possible with this one. Posterior fixation is possible is better with this fracture line. Type 3 may be managed with rigid collar. Actually, somebody may think or may still consider using halo, but halo is not a very easy thing to carry, and especially in the older persons, in geriatric patients, it's better not to use because the complications of halo is quite high. Let's come to the Hangman fractures. Effendi classification have been used since 1981, and there are 3 types. But Levin and Edwards have modified it in 1985. Type 1 has less than 3 millimeter displacement. You can manage it with a hard collar. Type 2 is more than 3 millimeter displacement, halo or anterior or posterior fixation. This is quite still discussable. Type 2A has more than 3 millimeter displacement and more than 11-degree angulation. Those cases must always be operated either with anterior or posterior fixation and isthmus repair. If you go from backward, then you can also repair the isthmus. Actually, as you know, Hangman fractures may also called as traumatic spondylolisthesis of C2. Type 3, the facets are dislocated, even locked at this level. And they are all more than 3 millimeter displacement and more than 11-degree angulation. Most surgeons prefer a posterior fixation in this case. Let's come to a unique upper cervical trauma, a combined atlas and axis fractures. Dickman has classified them in 4 groups, and the percentages of them is mostly 40% is C1 type 2 odontoid fractures, and these are the others. What are the options for management? if there is a C1 type 2 odontoid fracture, if it's a stable, rigid collar or halo is okay. If it's unstable, atlantodental interval is more than 5 millimeter, halo or surgical fixation are options. If there is a C1 and different type of C2 body fracture, rigid collar is okay. It's mostly considered as stable. If it's a C1 and type 3 odontoid fracture, halo or surgical fixation. If there is stable Hangman fracture together with atlas fracture, then rigid collar or halo. If it's an unstable Hangman, then halo or surgical fixation are the options. So it's not very straightforward. So then stability must also be searched for by radiologic criteria mostly. And this is my algorithm. In case of trauma, mostly the main instability is an atlanto-occipital instability. We must look at it if it's a reducible or irreducible. If it's a reducible atlanto-occipital instability, mostly we can make just C1, C2 fusion. If it's irreducible one, which is not common in acute trauma, but in cases coming you lately, I mean, more than 2 weeks or months later, so then it may be irreducible one, so then you may need a anterior decompression plus posterior fixation. If there is some sort of occipitocervical instability, then we must look also reducibility. If it's reducible, occiput C1, C2 fusion. If it's irreducible, anterior decompression plus posterior fixation, occipitocervical fixation. We need. Probably very shortly, I can talk about the craniocervical stabilization techniques. I will try to summarize them. Odontoid screw fixation, as you have seen in my slides, type 2B fractures of odontoid 2 fractures. These are good candidates, especially if it is a posterior dislocation. It's also a good candidate. So then the obliquity of the fracture line, as I mentioned before, is very important. Transverse ligament must not be ruptured. If it is ruptured, it's better not to make an odontoid screw fixation. Non-reduced fractures are not good candidates. Some surgeons do not like to do anterior dislocations. You can use 2 C-arm together or 1 C-arm, then you turn it to AP and lateral view very often during surgery. And you can place a gauze into the mouth of the patient to see the on AP view, the odontoid process, because it may be conjoined with the teeth itself. So then by opening the mouth, you will see it better. Your incision line must be at C5, C6, and you must have a good angulation to reach the C2-3 disc space and place a key wire inside. And during that period, you must reduce the dislocation if there is some. Some surgeons prefer 2-screw technique, but I don't use it. And it is criticized if you use 2 screws, the screw diameter is about 3.5 millimeter. So then you will get less fusion surface, because the base of the odontoid is about 0.8 centimeters diameter. What are the alternatives to that? Anterior C1, C2 transarticular screwing is one alternative. C1, C2 plating is another alternative, but technically demanding. C1, C2 wire fixation, we have been doing that for many years. The most effective one is the Gallie fusion, but the original authors have described this technique after this wiring with a H graft taken from the posterior iliac crest. They need, however, a post-op halo brace. The authors have placed halo brace afterwards. This is a historic one, Halifax clamp fixation. We have left it. It is not in the market yet, since they were dislodging with the rotational movements of the head. Another one is a C1, C2 transarticular screw fixation. Actually, there are three techniques for that. Anterior, I have shown you a few slides before. Lateral is very technically demanding, but posterior one has been used by many years. It is a so-called modifier technique. But you need to make a very inclined screw entry to the C2, C3, from the C2, C3 facet entry. Some surgeons may prefer to make another incision at T1, T2 level, so then your screwdriver will take a angulation like this. In case with severe osteoporosis and upper thoracic kyphosis, it's not recommended. And another thing is the variations of the vertebral artery. Before surgery, you must have sagittal CT scans in the passing from the lateral part of the vertebral structures, so then you can see the entry point, the passing of the screw trajectory. If there is a so-called high riding vertebral artery, it is quite possible to injure the vertebral artery on one side. According to some anatomical studies, 20% of C2 body architecture do not allow to pass a safe trajectory. I mean, in 20% of the normal population, the vertebral artery will be injured. Besides, some surgeons prefer also adding some wire in addition to the magyar screwing. So because of that important complication, many surgeons have left it, and they have came to use the Goyle-Harms screwing. It was first introduced by Goyle, then popularized by Harms in 2001. This is a C1 lateral mass screw and C2 pedicle screw. Because of the lower risk of injury to the vertebral artery and very good purchase of the screws, you can prefer this technique. C2 pedicle screws must be directed 25-degree medial and rostral. This is the entry point for C2 pedicle screw. Yes. What about occipitocervical fixation? Probably there have been a trend to make, in most of the upper cervical problems, to place an occipitocervical fixation, even if there is just a C1, C2 instability, many surgeons have got too many occipitocervical fixations. It's not a good option because there are significant complications of occipitocervical fixation. These are some historical things, the Lucke-Harschel-Ransford loops. We were using that together with sometimes with methyl methacrylate. This is some cases from my own series. Yes, I can just skip them. But recently, we have those rod plate and screw combinations, which make it very easy to apply occipitocervical fixation. These are some pictures from my own usage. And you can see in 1996, I was doing a hook clamp and a bent rod system, and then very long U-shaped rod systems. Then in 2012, we started to use shorter fixations. Evolution of the technique was long fixation applications of all craniocervical pathologies without reduction. Now we are doing shorter fixations, separate indications, reductions could mostly be achieved. What are the complications? CSF fistula may happen, cerebellar hematoma, and hardware-related complications. Screw loosening, pseudoarthrosis, and instrument breakage is very common. And most important thing is that the patient, after a occipitocervical fixation, have difficulty to rotate his or her head on all directions. So it is really a very disabling thing to make an occipitocervical fixation. Non-union is quite high. This is one of the cases I have operated years before. A rod breakage may happen because of non-union. So, in conclusion, C1 lateral mass, C2 pedicle screws are safer than C1, C2 are transarticular screws. Basilar invagination can be reduced with posterior surgery. It's not trauma, but I wanted to mention this. In case of occipitocervical fixation, shorter fixation must be tried, and autographs are better for fusions. Thank you for listening to me.
Okay, Salman.
Thank you, Mehmet. That was a wonderful talk. You know, just taking us through all CV junction, various fractures, and how you're going to deal with them, and what are the important things to look at when you're in the ER or when you're looking at these patients and their scans, and how do you diagnose and what criteria you should use. I think all that is wonderful. Obviously, you need to go back and read these up and just polish it. It's important that we know this. Do we have any questions? If you have any questions, please. So there's a question, what is the entry point for C1 lateral mass from Dr. Zafdam?
Yeah, actually, you must have a good dissection at that point because the venous plexus are very rich there, and you must see the lateral part of the atlas arch, and just below that you'll feel with a Panfield dissector, you'll feel the lateral mass. You can remove a small part of the arch and then directly come to the drill the lateral mass, and 24 to 28 millimeter length screw is enough.
There is a question, Mehmet. Do you remove the C2 ganglion?
In case I'm trying to reduce buzzer imagination. I do. I cut it because in order to enter the C1, C2 joint, this is a very robust ganglion. It doesn't allow you to place any spacer or any graft inside the joint. In buzzer imagination, yes. But in trauma cases, no, it's not necessary. Just screw C1 lateral mass and C2 pedicle screw.
Okay, and do you have any more questions? I think the talk was so wonderful. So your classifications for each fracture that you described, can you just revise the names so that people can go and look them up?
Yeah. Somebody is asking about the YouTube channel. Probably you will deliver, or John will deliver it. The YouTube channel afterwards.
Yeah, initial half of the presentation did not go through on YouTube, so John will look into that. Don't worry.
Yes,
Salman,
I'll put the
questions for your talk.
Yeah, I'll put the link on the chat box of the YouTube channel where it's going to go.
Sure. Okay, I've already replied to the questions that were put to me via this only, so that all is already done.
May I say something?
Sure.
I'm Nikolaos Sirmos from Thessaloniki, Greece. I want to only tell many greetings to my dearest friend Mehmet Zileli. I met him during the Mediterranean spine courses. He's a great friend and also a great teacher for me, and a great friend of the Greek neurosurgery. Dear Mehmet, many greetings. I'm very happy to see you again, and all the best. Also, my dearest greetings to Salman Sharif, also my friend from the spine courses all over the Mediterranean area. Also the Professor Sharif, also many greetings, and stay well and stay safe. It's a great honor to me to participate in these very good meetings that John Bennett organizes. I'm very happy and very pleased and very honored.
Thank you, Nicola.
Maybe in the future, from the coronavirus now that we have, maybe in the nearest future to see you again, and it will be a great honor for me to see you again, both Mehmet Zileli and Salman Sharif.
I wish the same. Yeah, we must turn back to normal very soon.
And all my best wishes also to Salman Sharif and Mehmet.
Thank you.
Thank you very much. We will switch on the mic for John. Can you switch on the mic for Nikolai Piv?
Sure.
And his video as well. Sorry, Nikolai, we are not ignoring you. Just trying to switch you on. Are you there, Nikolai?
No, I didn't think so.
There
Yes,
you go.
I'm
There you
here. I didn't think you're ignoring me, so I'm starting.
So I see you're in theater. What are you up to? Hello?
Are you okay, Nick? Hello, Nick.
Nikolai, are you there? All hospital Wi-Fi's are awful in UK.
He disappeared.
Okay.
UK has no good internet connections.
No, the hospitals don't have good internet connections.
Well, you know what? Wait, you could say hello to Atul. Atul Goel's here.
Hi, Atul.
Are you there, Atul? He stopped it. He may have stepped out again. Okay, Atul, are you there?
Yes, very much.
Say hello to Salman and Mehmet and Nick.
Yes, I heard the little bit of lecture of Mehmet, not so much. You know, I'm enjoying my holidays, and I had slept off. I put an alarm for 5 o'clock to hear your talks, but somehow I didn't get up in time. But I heard a little bit of Mehmet's talk, and as usual, Mehmet is a different man. When he talks and when he interacts, he's different. But great talk.
Welcome.
Thank you, Mehmet. Everything okay,
Everything
Mehmet?
is fine. Everything is fine.
Salman?
Yes, Atul, as always, it's good to hear from you. And you need that rest. You deserve that.
Too much. But I had planned to get up at exactly at 5, but couldn't. But you started late or what? Because it is.
No, we started at 5. 5 our time, which is 5:30 your time.
Okay.
Yes, Nick fell off there, Salman. So.
Atul can tell us something about basilar invagination in the meantime.
Yeah, I just heard Mehmet responding on C2 ganglion. So should I make a comment on C2 ganglion?
Sure.
Please do it.
Yeah, C2 ganglion is a quite a large ganglion. Sometimes in vertical height it may reach about 8 millimeters to 1 centimeter. So it is quite a large and thick one. So it occupies that space, and to expose the joint can sometimes become difficult in the presence of C2 ganglion. I used to cut C2 actually, when I started cutting C2 ganglion long time ago, and I reported it, of course, and I used to cut it all the time to get exposure of the C1 and C2 and the joint. But as I went ahead further in my business of craniovertebral junction, I have now almost stopped doing C2 ganglion resection. And I dissect it, I mobilize it up and down. I can expose the joint, I can do C1 exposure. But sometimes, as even Mehmet said, when there is basilar invagination, assimilation of atlas, and when there is severe basilar invagination, I will cut the C2 ganglion. Because for me, exposure of the region and completion of the project, my project is 3 points. One is to expose the C1, second is to expose the joint, and third is to do instrumentation. All these 3 have to be completed under vision. So when the vision is not there, I think cut the ganglion. There is no real harm in cutting the ganglion. And it exposes the window to C1, C2 joint, and wonderful. Means the procedure of sectioning of C2 ganglion completely gives you a new world of exposure. So never hesitate, but avoid. That is my, that is my strategy.
Very good. That sounds very good. There's a question, Mehmet, do you operate early even if there are respiratory disorders with upper cervical spine injuries?
Yeah, it depends actually. It depends on the pathology. If there is significant instability to achieve a good alignment and to decompress the spinal cord, it may be necessary. For instance, I haven't seen any single case of leaving occipitocervical dislocation. I've seen a few, but they all were dead after 2-3 days. I would love to fixate them, but there was no such cases. Even there is no respiratory movements.
Okay, and what about even if they have a big contusion, like, we talked about that basics score, and if the basic score is 4 with big contusion going all the way up and down with hemorrhages in the cord, would you still do this, give them the chance?
Actually, your talk was very important that you were telling that Asia A score patients, 11% are getting some recovery or improvement to other levels. They become later Asia C or D. So then why don't you give them the chance of getting improved. In fact,
What happened?
I guess considering them as a Asia A at the beginning is a lack of good examination, because it's quite common even in our practice. A patient comes that has no movement in the legs and arms, but the resident in the night or neurosurgeon in the night does not try to examine the perianal area. There are some sensation there. We then missed it. I mean, some of those cases of 11% have been in 11% because they are not examined well.
Yeah, I think there are two aspects, as you said, there could be spinal shock, one, or there could be that, you know, the examination was not done. So the rule is that you have to examine every hour for first 24 hours and document. And from then onwards, if the attending feels that, oh, we have done this surgery or we have done whatever treatment, then it's okay. Otherwise, every 2 hours for next 48 hours as well. And actual neurology, you will know in a patient in 72 hours, really. So I think in the meantime, you need to hypertense them. You need to make sure that, you know, they're decompressed. If they require decompression, if they're unstable, you stabilize them. If the tongues need to go in, you do that. In some patients, we use haldi, turmeric, as a routine. In some patients, I use ralazole, and these are some of the things that have been used and have shown benefit. But, you know, the main benefit that's been shown is you operate early, you hypertense them, and at the same time, you know, you keep them in high dependency unit where they're aggressively nursed. They don't develop bed sores, etc. You get them to stand up on tilt table, etc. And if you do all that and you make sure that other complications like chest problems do not happen, then there may be a chance that these patients will improve and will do have some kind of reasonable recovery afterwards.
You know, Salman, in the past, we had the knowledge that in case the patient has no respiration, and in case the blood pressure is very low, it's better to wait till they recovers. But with the current very nice intensive care unit tools, we have dopamine to increase the blood pressure. We have very nice respirators. We have very nice intensive care units. We can recover them, and then we can make the patients ready for surgery.
Okay, good. Nikolai, can you try again, please?
Yes, I am trying to switch my my desktop now. Okay. Okay. Do you see it now?
Yep,
Yes.
that's fine. Carry on. So Nikolai Peeve is a dear friend.
Hi, everybody. I'm sorry I disappeared.
I'm sorry, Nikolai, I'll just introduce you. Nikolai, I'm sure many people know, as given lots of talks here, is actually has been a friend for a long time. We have worked in a lot of courses, and also been involved in various societies, spine societies. He's working in Belfast as spine surgeon, and lots of interest in, and even did COVID duty for a little while. So Nikolai, off you go.
Hi, everybody. Thank you so much for the introduction, and thank you everybody for having me the opportunity to be here. Hi to Mehmet and to all the moderators. So pleasure as usual. Please excuse me for the outfit. I'm working today. I'm in theater. I just peeled off to deliver that lecture, and I'm going back to theater. I'll try to make it as interactive as possible. So I've seen the other lectures, and I've heard the majority of the things that I will speak to you about, but hopefully I'll give you something interesting as well. So subaxial spine, and in general, the cervical spine still represents major issue. There is a lot of fatalities and a lot of mortality and problems because of cervical trauma, and we have to deal with the consequences as surgeons, neurosurgeons, spinal surgeons. About 15 to 20% of the fractures will be complicated with severe neurological deficit, and about 50% of the C spine injuries will be happening in that C6, C7 region. About 60 to 70% of the fractures will be a result of road traffic accidents, and about 30–40% be caused by sport injury and assaults. So just to remind you, cervical spine is the most mobile segment of your spine, and the C0, C1, C2 segment is quite different anatomically from the subaxial segment, which is C3 down to C7. Normally, you should have lordotic configuration of your C-spine. Anterior and posterior ligaments are very important for the integrity of the anterior middle column, and the posterior column is maintained by a complex ligamentous system. The posterior column is the main weight-bearing structure. About 70–80% of the load goes through the posterior column, and this is unlike the thoracic and lumbar, where the ratio is flipped over, where 70–80% goes through the anterior two columns. The mechanism of injury is important for the injuries that you're gonna analyze and treat, so it's worth establishing that. So there is usually 6 mechanisms of injury that can cause problems and traumatic changes. This is flexion, extension, compression, destruction, torsion, shear, or combination of all these. You can see the different axes of different planes where this can happen. So management of the subaxial cervical trauma, of course, involves the patient assessment in the very beginning. It starts from the very beginning. Resuscitation, establishing the consciousness level. Immobilization is a critical point here. Then you have to go through history, physical examination, neurological examination. You have to examine radiologically, and then try to classify, and then finally go to the management plan. Just make sure that you stabilize the neck properly, and just bear in mind that stabilizing the neck is emergency, but to clear the neck is not as urgent as stabilizing it. So be careful and think about that. So management of the subaxial spine, do we have so much level 1 evidence? Let's see that. Actually, we don't have so much. We have about 9–10 studies which show that the methylprednisolone is not working. This was also already mentioned by Salman. Gangliosides are not working. We have about 3–4 studies about the CT as being the most reliable and accurate investigation for thoracolumbar trauma. And that's it. The rest, we decide based on case series and spine expert groups, but we don't have grade 1 evidence for many of the things that we do. So the mainstay of the treatment of the subaxial cervical spine is trying to classify. And in order to classify properly, we need a classification that gives you objective clinical and imaging assessment. It will provide standardized grading of the trauma. Will identify any type of injury without miss. I will facilitate the decision making in the fracture, whether the fracture is stable or not, and then we'll give you direction to treat, to fix or not to fix in our case. Unfortunately, we are still in search for the ideal classification that will comply in 100% of the cases with the above criteria. We don't have it as yet. So the first classification that was attempted was by Böhler in 1930, and he described 6 types of fractures, and he realized the importance of the mechanism, and his classification was based mainly on plain X-rays. That is, of course, historical significance now. Then the first sophisticated classification was done by Holsworth, where he defined 2 columns. With anterior and posterior column, and he stressed the importance of the posterior ligaments. Then the 2-column classification evolved to 3-column classification by Dennis that was published in 1983. and he postulated the tree column, and he postulated that it's unstable when two adjacent columns are involved. And this is a classification that is still in use in many centers because it's very simple. And then the first comprehensive one came when Magarel and Eby published their classification based on nearly 1,800 cases, which later evolved to AO classification. So someone already spoke about the AO classification. This is probably one of the most complex and comprehensive classification that we have now. It will identify 9 main groups of patients based on the different mechanisms of injury and different morphology, and will add additional features based on facet joint trauma, neurological status, and also modifiers. Type A is mainly compression fractures with the four types that we have already mentioned in Salman's talk. Type B is injuries of the tension band, anterior or posterior. We already spoke about that, so I will skip further. And type C is a translational injury with displacement in any direction from the vertebral body relative to another. Usually, type C is combined with type or A or B or different combinations. I think we have to, in the cervical subaxial spine, we talk about also the facets, and the facets contribute further for classification. The morphology of the fracture, as you can see from F1 to non-displaced facets, which is below 1 centimeter and below 40% of the lateral mass involvement, which is believed to be stable, and the rest of the types are mostly unstable. We have the neurological status, which is important also modifier for your decision making. And then we have general modifiers like the posterior capsule ligamentous injury. We have the morphology of the disc herniation, which is also something that will modify and direct you for your treatment. And we have different general conditions like stiffening of the bone and ligamentous complex, like ankylosing spondylitis, like dish. And then M4 is possible vertex in your treatment strategies. So unfortunately, this despite it is a very comprehensive classification and gives you a lot of variables, that can be sometimes tricky, and that causes problems with the everyday use. Despite all of us are aware of the AO classification, are practically not in all the centers this is being used nowadays, and in many centers they still use the other classifications which are easier to use. This is an interesting research that probably explains that. The authors tried to compare the AO classification with the old Dennis classification. 5 observers were trying to classify different traumatic patients with the 2 classifications. And as you can see, with AO classification, the observers reached 0.31 inter-observer reliability. And based on CT and based on MRI, it's even less. If they combine CT with MRI, they managed to reach nearly 0.5. As you can see with the Dennis classification, inter-observer is 0.6 with the CT. Of course, this was based on the old, not on the last classification that was issued by AO, but still the new classification is, if anything, it's a bit more complex. So this is a real problem of the AO classification, its complexity, and although it's a very comprehensive, it is difficult to use on everyday use. So This is a treatment concept that you can base on the Yale classification. As you can see, all the B types, all the C types are mostly surgically treated. All the unstable facet types starting from F2 down to F4 are mostly surgically treated, irrespective of the rest. With A types, you can choose to treat conservatively or surgically. With A0 and A1, of course, possible to treat conservatively, but A2 and A3 sometimes gives you a gray zone based on the other modifiers. Then it is difficult to establish a proper plan of action, and then you have to rely on your personal experience or the experience of your group. So the big criticism of that classification, as we said, is that it is insufficient for the anterior column. It is complex for everyday use, and also has relatively low inter-observer reliability. Sorry. Another classification that is very popular and that was again mentioned today by Salman was the subaxial cervical spine injury classification by Vaccaro, or known as SLIC classification. In that classification, we have three main categories, which is the injury morphology, discoligamentous complex, and also the neurological status. It's a point system. You assign numerical values to the main three categories, and then you sum together, and then based on the score, you have a guidance for your treatment strategy. If it's less than 4, you treat conservatively. If it's more than 5, you treat surgically. And if you have 4, again, you have a gray area where you can apply one or the other based on your experience. This is the classification again. And this is the point system that you can, these are the points that you can assign in the different domains. I'm not going to go in details with that. The main criticism of that classification is that the mechanism of injury is not well reflected. The posterior ligamentous complex needs MRI scan. This is not always available in all the centers and 24/7. And then the neurological status will need a awake patient that is alert, oriented, and cooperative. So just to remind you again, this is the ideal classification. Unfortunately, we still don't have that, still to be established. Management of the subaxial spine can be, as we said so far, conservative with immobilization. You can immobilize with hard collar, or you can immobilize with hollow vest. Be careful with the snake in motion. This was mentioned by Mehmet already. This is a good paper that will give you information about that. Because of the snake, immobilization could be tricky with the halo vest and actually can give you worse result than without treating the patient without the halo vest. So you have to be very selective. In my center, at least, we are still using halo vest, but less and less. So if decided to treat the fracture, we have the following goals. We have to do reduction in case there is any translation. We have to do decompression in case there is compression of the neural elements, and we have to stabilize. And we can use anterior approach, posterior approach, or combined anterior-posterior approach. So speaking about the anterior approaches, we have advantages and disadvantages with any of those. With the anterior approach, we have good anterior decompression. We can achieve good neurological improvement in case the problem is mainly due to anterior compression. We have a traumatic approach, and we have supine position, which is easier to achieve in trauma patients, especially if you have multi-trauma patient. The disadvantages, you have limited number of motion segments that you can that you can address. If it's more than 3 motion segments, usually this is difficult and probably should not be considered. You have potential for complications, and you have poor access to the transitional zones. Unlike the anterior approach, the posterior approach also has the advantages that it will give you a rigid fixation, it will give you good foraminal decompression, it can give you good deformity correction, and also you have no problems to go to the transitional zones. The disadvantages are that in case you have anterior compression, you may be difficult to decompress. The prone position is also something that could be challenging, and you may have significant blood loss. In some cases, and not only anterior or posterior approach is not possible to be applied isolated, and you may need to combine us, like with this case where we have 3-column injury. So I will conclude here. Managing the subaxial trauma. When you manage the subaxial trauma, clarifying the mechanism is very important for your treatment. Imaging will give you information about the mechanism, but you have to go to history and also to the neurological status. There is no perfect classification. We are still looking for that. Many classifications are there that you can use, but you have to use them wise because they are not ideal. Management varies in different institutions and based on different policies, surgeon preferences, and philosophy. And there is quite often more than one right approach to one and the same problem. And then classifications help for decision making and complications, communication and documentation. And each case should be discussed individually. Thank you so much.
Nikolai, that was excellent. I think you gave a very nice overview of the whole subaxial spine. And you made them revise the classification again, which is good because unless you do it again and again, you won't remember it. So thank you for that. Excellent talk. Really enjoyed that. Mehmet, do you have any questions for Nikolai before we close?
It's quite nice to stress that a spine classification for subaxial spine cervical trauma is a very difficult to place everything. And the SLIX classification is nicer. But even with SLIX, you cannot well define whether you have to come from anterior or posterior. You can, they are not nicely placed in place.
Yeah, I think I would suggest that WFNS Spine Committee should have a consensus on this and come up with another classification which is able to tackle all the problems.
Maybe combination of all.
Yeah,
probably.
we can.
Why not? Why not?
Okay, great. I think it was wonderful to hear from great speakers. I think I really enjoyed both the talks, learned loads as always. And John, it was really nice of you to host us. We're really grateful and hope to see you soon in future.
Okay, Salman, can you tell us about your lectures that you're presenting now every day, right?
Yeah, so for example, tomorrow we have Ramesh Nair, and Ramesh Nair is going to be from UK. He's going to be talking about meningioma surgery principles. Mm-hmm. So basic principles of taking out meningiomas, concepts, pre-op embolization, etc., and surgical technique. And then we have Adrian Karkas from Puerto Rico, and he's going to be talking about principles of endoscopy surgery. So general principles, what you need to know, you know, all the things that when you're starting out endoscopy or even if you've done quite a few, basic stuff that you need to know that is changing and new stuff that's out there that you can do and use and able to use it yourself. Imad Kanan tomorrow is showing a case. Then day after tomorrow, this is our 4th session of the module that we are doing on ventricular anatomy. So we'll finish that on Thursday. And then from next week, we're going to be starting the module on cerebrum. And that module is again of 6 lectures, and they're all are based on roton neuroanatomy. And we have 4 experts every day telling us what clinical application of those and that anatomical lectures are, and it's wonderful, and I learned so much from those. And I think on Friday we have 2 deformity talks. One from Shan Raza from he is actually Hassan Raza, who is from Harvard. He's associate professor of deformity surgery at Harvard. And then we have Onur Yaman from Istanbul, who will be talking about deformity again. And to follow that up, we have IFNE meeting on Saturday, and then we have a couple of other meetings, and then Monday we have something about skull base again. So there's something happening every day. There is a break for 4 days for Eid that we have from, I think, 24th to 27th, we have the break.
Okay, very good. A lot of time for education now, which is great. Does anyone on the panel want to say hello to Salman, Nick, or Mehmed, just to check in? Now's your chance.
A lot of friends here. Pragnesh Bhatt from UK is here. And so many friends that I know who have been in touch with us are here as well, and it's wonderful. And thank you all. It's because of you we are doing this.
Okay, very good. Okay, is there anyone that wants to check in before we close? Apparently not. Okay, very good. Thanks, Salman, Nick, and Mehmed, and we'll be seeing you in the future. And thank all the panelists.
Thank you, John. Thank you, Salman. Goodbye.
Okay, good day. Thank you. Thank you, Nick. Bye-bye.